So good afternoon, good morning, good evening. It's a real privilege today to be here. And first of all, a huge thank you to the Transplantation Society for agreeing to come and tell us, the transplant community, to inform us and help us move forwards with these questions on vaccination for transplant recipients, of which I am one. Let me introduce myself. My name is Liz Schick. I am a liver recipient, transplanted 23 years now, and I am the secretary of the World Transplant Games Federation. I was lucky enough to experience COVID last November, spent 11 days in bed and was pretty sick, and I have also had 2 doses of COVID vaccine. So now I'm grown up and vaccinated. So here we go. Today, our community here online, we have 60% transplant recipients who have logged in today to listen to us, 30% from the medical community, and 10% donor families, living donors, and family members. So a very wide selection of people, but of course, a lot of transplant recipients like myself online. We have the World Transplant Games Federation. We have had a campaign out there with over 30,000 engagements about this talk today. And we have had around 10,000 likes. Most of our member countries, you may know that the World Transplant Games Federation have over 60 member countries in the Federation. We have a representative for more or less every country. And I think a lot of our member associations will be watching the recorded version of this. And I know, being in the Swiss team, that we will be watching on Zoom the recorded version and translating in our different national languages. So we've got a really wide outreach. So without more ado, I'd like to thank all the speakers in advance, and we're really looking forward to hearing what you've got to tell us, because we want to know. Thank you.
Liz, thanks so much for that nice introduction. I'm Camille Nelson-Cotton. I'm at Massachusetts General Hospital in Boston in the United States. And I've been involved in the Transplantation Society for quite a long time now. I'm an infectious disease specialist. We have a wonderful lineup of speakers, and given that the attendees, I see you're coming from all over the world. So we have speakers where we tried to encompass most continents. So without further ado, I'm going to introduce Dr. Stephen Chadman from Sydney, Australia, who's a transplant nephrologist, and he will kick us off.
Camille, thanks very much, and good evening to everybody from here in Sydney, Australia. What I have in front of you is a heat map that looks to have gone grey on the screen, but what that showed was the burden of COVID-19 in February this year, where we had nearly 100 million cases worldwide, causing 2.3 million deaths. And as I scroll to the second slide, there we go. What we can see is as we move through to April, only 2 months later, again, we've lost the color there, but in real life, that went from red to purples very much, particularly in countries where vaccination programs had really kicked in. The UK saw a massive reduction in caseloads on a weekly basis, going down to 30 per 100,000 population. The USA, which has had a moderately successful vaccination program of the general community, saw about a 75% reduction in weekly cases of COVID-19. France, which had a slower uptake of vaccination, had a slower response. So the message I want to get here is that the burden of COVID over the past 2 months has diminished modestly worldwide in relation to the ability of countries to effectively vaccinate their populations. What I'd like to do now is talk about the burden of COVID-19 in kidney transplant recipients. In some of the early data we received early last year from places like Montefiore Center in New York gave us great cause for alarm. In this case series of 36 consecutive kidney transplant recipients who were infected with COVID-19 in New York, who included a range of ages and ethnicities with the usual spectrum of comorbid states such as diabetes, who were receiving fairly typical immunosuppression. We saw the usual array of symptoms, cough, flu-like symptoms that we've seen in the general community, but what we were truly troubled by was the higher rate of death and hospitalisation that we saw here. As you can see, 28% of this cohort of people actually died to the disease. The majority of these had been admitted to hospital and had a typical pneumonic illness with a protracted stay in ICU. But one of the other things that really worried us were that two relatively young patients who were recently transplanted died very rapidly in their homes. So this sort of data from America was quickly matched by similar data that arrived from London, from Spain and Italy. And this is the sort of severe outcomes that led many transplantation programs around the world to suspend their programs and stop transplanting. And in fact, that is what we did in Australia. We saw an initial outburst of COVID-19 in our general community. By March, we were seeing 400 cases per week, and we stopped transplantation across the country, principally due to the initiation of social distancing, hand hygiene, and other public health measures. Australia was able to get on top of this outbreak very rapidly, and we were able to resume transplanting again 1 month later. However, the impact here from a transplant perspective was that over the rest of the year, we saw a 30% reduction in the number of transplants we could perform, which very much mirrored the state in the United States, in Spain, France, and the United Kingdom, countries where we saw a very much greater impact of COVID-19. And the message here, I think, is that COVID-19 has impacted all countries globally, and particularly our transplant populations. We were able to assemble a group of patients and their carers who had been on the wait list at the time of transplant suspension in Australia. And what this thematic discussion revealed were important themes about the impact of this on patients. Patients reported disappointment and devastation with the suspension of their plans for transplantation. They felt helpless and vulnerable. They'd lost control, and some had lost hope. They felt great stress through the uncertainty of how long will this continue and when will things change. We exacerbated existing health burdens, and people really struggled with how to sustain their health. Ultimately, in Australia, we have only seen 21 cases among all of our kidney transplant recipients, which culminated in 2 deaths. This is against a relatively low burden in the general population, where we've seen 30,000 cases from the population of 2.6 million Australians, resulting in less than 1,000 deaths. But what you can see here is that the mortality rate among kidney transplant recipients was approximately 3-fold higher than that for the general population. And as we now see more mature data coming from some of the transplant centres, such as this data from the Paris group, who looked at the March-April 2020 impact of COVID-19 on their population, the same themes come true. That is that kidney transplant recipients and all solid organ transplant recipients appear to be 3 to 5 times as likely as the general population to acquire COVID-19. And once they have it, they appear to be 3 to 10 times more likely to get severe disease or in fact succumb to COVID-19. So the point of today's discussion is to provide you with the data that you need to make an informed decision about whether or not you will receive vaccination. This slide from The Economist Journal shows that across the globe, there is greatly differing appetites for immunisation. The data I've presented to you today hopefully will persuade you that COVID-19 presents such a large risk to you that immunisation really is something you should do. So in conclusion, ladies and gentlemen, I've shown that COVID-19 is a big problem for transplant recipients. Transplant recipients are more likely to get infected than the general population and much more likely to get sick or die. The COVID waves we have seen in the past are likely to return and to do so in ongoing waves. The high risks of being infected and incurring serious disease or even death really should be considered in your decision about vaccination. We know that vaccination coupled with ongoing hygiene, social distancing are critical in minimising the impact and spread of this disease. And the high risks of being infected and developing severe or fatal COVID-19 should be considered by you at the end of this seminar in terms of whether or not you will accept vaccination, and I seriously hope that you will. At that stage, I'd like to hand back to Mike Eisen. Mike is an infectious diseases expert. Thanks very much, Mike.
Great. Great. Thanks, Steve. Good to see you, and thanks for the wonderful update. My name is Mike Eisen. I'm the Director of Transplant Infectious Disease at Northwestern University Feinberg School of Medicine, and currently the President of the Transplant Infectious Disease section of TTS. As soon as the slides come up, I'll be talking with you today about how the vaccines actually work. Here are my disclosures, nothing relevant to what I'll be talking about. So what we are trying to do is help our immune system respond to the spike protein, the little red things projecting off the gray virus, which is the SARS-CoV virus that causes COVID-19. That spike protein is what the virus uses to get into the cell. And when we make antibodies, the proteins that attach to these the spike protein, it prevents the virus from being able to dock to a cell and infect that cell, and as a result, prevents you from getting infected. We have a number of different vaccines, the RNA vaccines, where they've clipped a little piece of the spike DNA, or RNA in this case, and it is injected and produces the spike protein within the cell. This is the Moderna and Pfizer vaccine. The viral vector vaccine, like the Astrozeneca and Johnson vaccine, functions in a very similar way, where that code for the spike protein is put into a cold virus, an adenovirus, and that helps get the DNA into the cell, which in turn produces spike proteins that are expressed on the cell surface. And then there are inactivated viruses and protein, where either they take a whole SARS-CoV-2 and put chemicals in it that kill the virus, but the guts of the virus, such as the spike protein, are then injected into the individual. Or protein-based vaccines, where they create spike proteins and allow them to aggregate into these kind of star-like structures, and put them with what we call adjuvants, which is something that helps boost the immune responses. Once this is injected into the body, they can result in two different responses. The first is where we have T cells. These are the cells that help clear infections once someone becomes sick. These are activated by the viral proteins that are produced, either the spike protein, the nanoparticles of the vaccine, or the SARS-CoV-2 that's been inactivated in the inactivated vaccines. And then these T cells remain in our body for the remainder of our life, so that if we do get infected, it's these T cells that help protect us from getting very sick and dying from the infection. It's these cells that still develop even if there's changes in the virus, such as the variants that we've heard about, and help protect us from getting very sick if we get infected despite being vaccinated. What we are most interested in is producing antibodies, and these are what help protect us against primary infection. What ends up happening is either the spike protein on the vaccinated cell the nanoparticles in the protein-based vaccine or the virus particles in the inactivated vaccines simulate B cells, the cells that help us make antibodies. As a result, antibodies are produced, and some of these B cells go on to become what we call memory B cells and allow the vaccine to cause antibody production that lasts for a very long time. In the end, the way that these vaccines work is that the antibodies, when they're produced in response to either infection or vaccination, bind to a virus and prevent it from causing someone to get newly infected with COVID-19. Even if that doesn't work, if there aren't enough antibodies or they don't bind very well because the virus is mutated, the T cells help clear the virus more quickly and are responsible for reducing the risk of severe disease. And so this is why we have two end results of the vaccine. One, which is protection. And if the vaccine doesn't provide us protection against primary infection, it does reduce the risk of getting very sick, requiring hospitalization, or dying. So with that, I will turn it over to our next speaker, which is Alicia Pierotti.
Thank you, Mike. Hi, everyone. It's a pleasure to be here. And I will talk about vaccine safety, a very important issue in any vaccine and either in COVID-19 vaccine. I have no financial conflicts to disclosure. And the first thing that we think about COVID vaccine is safety, because after about 15 months since the first case of COVID-19 in December 2019, we have 13 approved vaccines to be used in the population around the world. And the first question is because the rapidly developed vaccines really safe, guarantee the safety? And the answer is yes. Ensuring the safety is and quality is a high priority in any vaccine development, and is not different in this case of COVID vaccine. And the fast track development and approved rates were possible because years of previous research on related viruses, faster ways to manufacture vaccines, funding allowing to run multiple trials in parallel, and regulatory moving faster than usual. But all the rigorous and multiple stage testing vaccines process, including the large numbers of clinical trials, have been done. And now we have these 3rd approved COVID-19 vaccines with more than 800 million doses of vaccines administered. It's important to say that any vaccine can cause side effects. And why does it happen? First, because the body immune system activation by the vaccine, exactly what Mike explained before. This is the most common side effects, usually last a few days and go away without any medication. We have also allergic reactions to vaccine components. It's possible with any vaccines, for example, anaphylaxis, and is extremely rare. And finally, we have some vaccines that can mimic the pathogenic mechanism of the disease, but is a concern of particularly concern for live attenuated vaccines. And none of the approved COVID vaccines at this moment has live attenuated virus in the component. So what means that COVID vaccine cannot make you sick with COVID-19 disease. Usually, these side effects occur during the first 2 weeks after the vaccination. And the most common side effects of getting a COVID vaccines are inflammatory reactions at local shot sites. This is more common, sore arm, redness, and swelling, and we can reduce pain and discomfort when you got the shot. We can use a clean, cool, wet washcloth over the area and use or exercise your arms. And we have also systemic common side effects like fever, low-grade fever, fatigue, headache, body itches, chills, and nausea. Those symptoms are often mild and last few days, no more than 2-3 days in general. But we have very rare side effects like hypersensitivity reactions, thromboembolic events, Bell's palsy, but it's very rare. And it's very important, the post-authorization monitoring, safety surveillance, not only the side effects, but also severe cases of COVID requiring hospitalization or causing death. This is very important for any vaccine, is much important for COVID vaccine and what is happening at this moment around the world. And what we have, we have some very rare side effects that is only possible to disclose after million and million of doses administered. And so we have seen some cases of anaphylaxis with Pfizer and Moderna vaccines based on messenger RNA vaccines. But it's very rare, it's 11 cases per each million doses administered. And this kind of effect was only possible to be observed after million people to be vaccinated. And also we have seen and we have reported, not so clear yet, some cases of cerebral venous sinus thrombosis and thrombosis in general with a non-replicating adenovirus vector-based DNA vaccines. But also, as you can see, it's very rare. These events were not possible to be observed during the clinical trials that even included thousands of people, but only when after vaccinated millions of people. Nevertheless, the World Health Organization and the European Medical Agency position is still keep vaccinate with COVID using those vaccines because the overall benefits of the vaccines preventing COVID-19 complications and deaths outweigh the risk of side effects. Of course, we can have local recommendations with specific restriction for each of these vaccines, but in general, the benefit is much, much better than any rare side effect that we have been observed. And considering allergy, what we can say to our patients, first, if you had an allergy reaction after first COVID-19 vaccine shot, talk with your doctor and the doctor can help you to choose the best way to go ahead if you need the second dose of COVID-19 vaccine. Second, if you are allergic to any ingredient of COVID-19 vaccine, also talk with your doctor to decide the best vaccine in your case. And if you are allergic to other types of vaccines, even this allergic was not severe, or an injectable therapy for another disease, is also important to talk with your doctor. But if you have history of allergies to oral medications, or if you have a family history, even a family history of severe allergy not related to vaccines, go ahead and you may get vaccination to any current available COVID-19 vaccine. And what about thromboembolic events, thrombotic events in general after vaccine? People who have received, at least at this moment, Astrozeneca or Janssen vaccine should seek medical assistance immediately if they develop one of the following symptoms, usually within 2 weeks of vaccination: shortness of breath, chest pain, swelling your leg, persistent abdominal pain, neurological symptoms including severe and persistent headaches or blurred vision, and tiny blood spots under the skin beyond the site of site injection. But my safety advice is, it's normal for some people to experience mild or moderate effects after being vaccinated, like pain at the short site, fever, chills. Individuals should alert their local health providers following vaccination if they experience any unexpected side effects, and no long-term side effects have been detected so far. And who should get the vaccine? COVID-19 vaccines are recommended for most people 18 years old or older, and but some countries are allowed for younger people, including those with pre-existing conditions of any kind, including hypertension, diabetes, asthma, and chronic pulmonary, liver, and kidney diseases, and autoimmune disorders. And for transplant recipients, all societies, international and national societies, recommend vaccine for transplant patients with any of the available approved vaccines, because none of them has any contraindication to transplant recipients. So all transplant recipients should get the vaccine as soon as possible. So I would like to take a message home. COVID-19 vaccines are very safe, and for now, following proven health measures is the best way to keep us safe, all of us. Get COVID vaccination as soon as possible, keep your hands clean, wear masks, and practice social distancing, and see your doctor if you have any questions. I would like only to say the situation to the COVID vaccine in the South and Central America. We know that have an imbalance to access and programs to vaccination, but we are working, all countries in the world are working to improve the vaccination coverage to the population. And this imbalance is related to the economies, of course, but there are several efforts to try to improve this imbalance. And although we have used limited vaccines in each country in this region, for example, Brazil, here in Brazil, we have Coronavac and Astrozeneca Vaccine. In Argentina, for example, with Sputnik, we are prepared and we have a lot of approved vaccine yet. And we also have a COVAX vaccines global platform for development, the manufacture and distribution of COVID-19 that estimated deliver 280 million vaccines until the end of 2021 to Latin America. So I would like to thank you, and I would like to invite Paul. Paul Harding is a nephrologist from Oxford University Hospital. Welcome, Paul, and thank you.
Thank you very much. Hopefully I get my slides soon. I think they're coming. I'd like to say hello to everybody, and it's great that you've joined whatever time it is, wherever you are. I hope you get some useful information out of this over the next 30 or 40 minutes or so. I thought it would be quite poignant to just say that pandemics come and go over the years, and this pandemic will go, and there is light at the end of the tunnel that we've all been involved in over the last 12 to 24 months, not just the transplant population, but for the whole general population of the world. Salisbury Cathedral was built in 1220 and has seen through the Black Death, where it supported sufferers, also the Spanish flu in the early 20th century, and now is one of our 50 major vaccination centres for the COVID vaccine, which I thought was quite poignant. I just click on that, sorry. I just go back one, that's it. So this just gives you a perspective of the amount of COVID cases in the different continents of the world. And as you can see, and as Steve had mentioned at the start, there's been a dominance in Europe from last year, and also in North America. And there's probably an overrepresentation here because in many countries there hasn't been great access to testing, and therefore, as we're seeing at present, there is a surge in India and also in South America. So we will see that there's all of the continents pretty much of the world are affected to a substantial degree. Looking at the European Union, this heat map shows if it's dark red, it means a very high infection level. And if it's light yellow, it means a low infection level. It only includes the countries in the European Union, and the grey countries are those that are not in the European Union and not supported data. And as you can see, that there currently is quite a substantial amount of activity in Paris and north part of France, but also in Poland, in Austria, and many parts of mainland Europe. There is quite a high second or third wave of infection. So this is a serious problem for all of our populations. Turning to some data from the United Kingdom, here we can see the two waves that we've had in the United Kingdom. The most recent one really started in the autumn. There was a slight dip after a short-term lockdown, which was not totally effective. And then after Christmas, there was a major surge, largely due to the new variant that was developed in the UK, which was more infectious. In parallel to that, from the end of December onwards, there's been a rapid rollout of the vaccination program in the United Kingdom, such that now 60% of the adult general population, that's anybody over the age of 18, has been vaccinated with at least one dose. And this is, as Steve had mentioned in the earlier talk, has helped to contribute to a dramatic fall in the number of cases and the number of hospitalizations and deaths, such that in the last month in our own institution in Oxford, we have not seen any deaths, and we've had single figure admissions with coronavirus. And as you can see, our daily number of cases throughout the whole UK population is now down to under 2,000, whereas the peak was 76,000 on the 4th of January. And you can see that we're also doing quite well at vaccinating both doses and giving full vaccination now. And we have nearly 7.5 million of the population, or about 16% of the adult population, who are fully vaccinated. The next slide just shows the same thing really, but re-emphasizing that there has been an impact on deaths. And of course, we believe that vaccination is effective for all individuals, including the transplant recipients. And it's important that there is widespread vaccination to prevent transmission of the virus between the different populations, including our own chronic disease population and our healthy transplant population. This shows vaccine uptake, and there's been a lot of concern that there may not be much uptake amongst the populations for vaccination. Well, here we see on the left, in the UK, people over the age of 50. In most of England now, there is over 95% of that population who've received a first dose. And you'll note at the bottom that there is a slightly lesser uptake in London, probably partly due to the very multicultural background of the London population, and to some extent some transient nature of the population as well. If you look at the ethnic minorities, you can see that in the white population, there's a very high uptake of over 95%, and it varies down to a level of about 70% in the Black population. But there is currently a very active program with community leaders setting up vaccine centers in religious institutions such as mosques to try and address this issue and to try and encourage any of the ethnic minorities who've not been vaccinated to be vaccinated, because as you will probably know, this population is at a higher risk of the disease than the white population in terms of serious disease and mortality. This is the current situation, data from the European Union of vaccine uptake in the different European Union countries. Now, if you compare this to so the UK, this is the population that had one dose of the vaccine over the age of 18. The UK was 60%, and you can see here it varies between about 7% and 31%. And so there's quite a long way to go, but every country has got an active vaccine program. Part of this is due to vaccine supply, part of it is due to establishment of a vaccine program and when it started, and it takes time to establish this and get this up and running. One issue is the issue over, I'm from Oxford, so I have to say a little bit about the Astrozeneca vaccine. And one of the issues has been the concerns of the side effects that you heard about earlier, particularly the thrombosis that's associated with these viral vector vaccines, and now seems to be associated to some extent, or maybe with the Johnson & Johnson vaccine as well. So as a result of this, the vaccine program with AstraZeneca was suspended in some European countries or reduced at the end of March. And that has a significant serious implication because, as you can see, the AstraZeneca vaccine towards the end of March was responsible for about 35 to 40% of the vaccines delivered. The other two vaccines commonly used currently in Europe are the Pfizer vaccine, which is in dark blue here, and in light blue, the Moderna vaccine. And it's going to be critical that we utilize all of the vaccines available in order to get to vaccine the whole population, or as many of the population as possible, as quickly as possible. So a little bit more about the AstraZeneca vaccine. We've already heard a bit about it. The World Health Organization are quite clear in saying that it is effective at preventing severe illness and death and is safe to be used in anybody over the age of 18 unless there is a medical contraindication. The two trials of the AstraZeneca vaccine have demonstrated that it is more effective. It's given, the doses are given slightly further apart at 3 months rather than at 4 weeks. 20.2 million doses have been given in the UK by the end of March this year. It's easy to use because the storage is easier, so therefore it is easier to take to countries that don't have such sophisticated storage and delivery systems. And one of the most important things for many people listening to this is that it is being distributed worldwide on a non-profit basis, and therefore it is affordable for many countries, whereas some of the other vaccines may cause some challenge on that front. The common side effects we've heard about, they are quite common, and many of the patients do get flu-like symptoms. 96% of our transplant population have been vaccinated, more than 50% of them with this vaccine, and certainly a number of them have had mild flu-like symptoms and fever for usually 24 to 48 hours. The data in Europe on blood clots is there are about a risk of about 4 per million people vaccinated, and the mortality is less than 1 per million people vaccinated. But I just want to put this slightly in perspective to say that the annual risk of an individual getting a blood clot in a major vein in the general population is 1 in 1,000, which is hugely more than this 1 in or 4 in a million risk. And secondly, if you are unfortunate to develop COVID, and as we've heard, COVID is at higher risk of developing a serious illness in a transplant population, there is at least a 25 to 30% risk of you then getting a major life-threatening blood clot as a result of the illness because it causes thrombosis. The UK transplant population currently is of about nearly 55,000 organ transplant recipients, of which approximately 40,000 are kidney recipients and 10,000 are liver recipients. Since January 2021, there's been an active priority program to vaccinate people with chronic conditions who are vulnerable, and more than 90% of the transplant population have received at least 1 dose of the vaccine, and an increasing proportion have now received a 2nd dose. And we have a current transplant waiting list in the UK of over 5,000 patients. Our current policy in Oxford, we transplant kidney, pancreas, islet and small bowel transplants, and all active patients on the waiting list are vaccinated or are asked to be vaccinated or have been vaccinated in order to be reactivated on the list. Out of our waiting list of about 160 patients, we only have 3 people that have refused. And those patients we arranged them to come up and have a clinic discussion with them to talk to them about the reasons behind that. And we were unable to persuade them to be vaccinated, but they still remain active on the waiting list. And a further issue for the living donors that are listening to this session, the policy in the UK now is that that potential living donors should be vaccinated before they donate. And that's purely to reduce the risk to them, particularly as they're having an unnecessary, if you like, operation and they're coming in for that. And we want to minimize the risk of transmission to them. So finally, I'll leave you this message that I think there's a clear message it should be sending to all of you patients. All of the healthcare providers on this webinar should be sending the message out to their cohort of patients that all of you are important people to your families, to your work, to your environment, to whatever. And you can reduce your risk by being vaccinated. So please don't be worried about the risk. The risks of not being vaccinated hugely outweigh the benefits. Thank you very much. I'll now pass over to Camille, that we heard from at the beginning, from Boston. Camille.
Great. Thanks very much. It's a real pleasure to be here. And thanks for all the speakers who have spoken thus far. It's really been a great medley. And, one thing that we are seeing and that many people are aware of in the chat is that overall, it looks as though the vaccines are resulting in less of a strong antibody response in transplant patients. I will say that this is definitely a work in progress. Many people saw the Johns Hopkins data where there was a significantly decreased antibody response after a single dose of vaccine. But again, this is a 2-part series. We're waiting on that Hopkins data to see what it will look like after a second dose of vaccine. And I just want to say that the antibody response is what's being measured, but they're not measuring another part that the vaccine triggers, which is called cellular immunity. Many of you know about cellular rejection. That's a different arm of the immune system. So we don't fully know how protective the vaccines are in transplant patients. We are seeing some breakthrough infections. We're having some transplant patients come into my hospital after 2 full doses of vaccine, and they are sick with COVID. So we know that transplant patients are less well protected, but we don't know the extent. So the real question is what to do about that in this setting. And so, So first of all, with limited vaccine supply and reduced vaccine effectiveness in organ transplant recipients, as Ligia Perotti said, continue with your social distancing, continue with your masking, continue with your hand hygiene. And unfortunately, transplant patients aren't out of the danger time yet. We had recommendations from the Center for Disease Control that said that basically vaccinated people can now go out and socialize with other vaccinated people. And if they're exposed, they don't have to quarantine and all that. They should avoid, however, all people should avoid medium and large size gatherings. Basically, what we sent as messaging to our transplant patients is that these rules don't apply. We don't consider transplant patients who've been vaccinated to be protected. So we are not there yet, okay? So I would say that these rules don't apply to transplant patients, unfortunately. Nonetheless, we're really cautiously optimistic that there's some partial protection. So we do recommend that transplant patients be vaccinated, and that's from the American Society of Transplantation, the Transplantation Society, many different organizations, but the coverage is probably reduced. Really important if you are thinking about going out. These are things to think about. You know, what's your disease rate in your community? It's really interesting listening to Steve Chadban speak versus, say, Michael Eisen or certainly Ligia Perotti, where there is a tremendous amount of disease in Brazil. We have a lot in Boston. So right now, I'm saying now is not the time for my patients to go out and run the risk of exposure. Also, what about travel? What is the setting of the event? How long is the event? You know, a short outdoor event where you can be masked may well be reasonable, you know, with a limited number of people, but a huge crowd indoors, I'm not going indoors now, and I'm not immunocompromised. So, you know, think about these details, and that may help guide your decision making. One of the biggest issues has been for us in the hospital, one of the biggest risks, it turns out, is not me going into the intensive care unit, taking care of very sick patients. It's actually my biggest risk has been having lunch with my friends. That's where we've seen the most disease transmission among doctors and nurses and other healthcare workers in the hospital. So one thing to just still be very cautious about is eating. We do recommend maintaining a 6-foot distance whenever possible, eat outdoors. Hand hygiene is key, and keep your mask on, except when you're actually eating. So that's another area to just still be cautious. But I do think it's reasonable that you could have lunch outdoors with a friend, you know, socially distanced and all that with precautions. I would do that if I were a transplant recipient. There were some nice guidelines sent out by the Center for Disease Control that probably many of you have seen. It seems like a very savvy audience. I really liked these guidelines because they talked about how to improve your mask. And they talked about how when both people are wearing a mask, it decreases the risk of aerosol exposure by about 95%. And there are ways to do that. As you can see here, there's actually a slightly better picture here where you could either do the standard medical procedure mask, although you can see that they highlight a bit of a side gap. There's the double mask, which is a cloth mask over a medical procedure mask. And I think that one is actually quite good. And for me, that's been quite wearable, and I feel comfortable with that, although we're not encouraged to do that in the hospital. And then there's C, which is this knotted medical mask that you can see over here on the side. I personally have tried to do one, doesn't fit my face. I think it fits different faces in different ways, but all of these are good options for you to think about. And honestly, even if you're vaccinated, unless you're in an area where there's very, very, very low disease transmission, maybe Australia, New Zealand, maybe some other areas that I don't know about right now, I would probably go with either, you know, B or C for the most part. This is just some of the details that they showed in that review, but it's basically what I wanted to emphasize is in gray is when there is no mask, there's a lot more exposure to aerosols. But if you, in dark blue here, you can see that mask on mask contact really greatly reduces the overall exposure to particles. And so I thought this was incredibly convincing as far as mask on mask contact. I will say that for those of you who might end up admitted to hospital, we would strongly recommend that you wear a mask whenever anyone else comes near your bed or wherever you are. And we have had transmissions in my hospital in part because people aren't wearing masks. I think that sometimes people trust doctors and nurses in the hospital, but this isn't about trust. This is about wearing a mask at any time that you're close to other people. And unfortunately, I'm getting a tremendous number of questions about travel. And for right now, I don't think transplant patients should be traveling. This is guidance from the CDC. And as you can see here, things to think about before you consider traveling are you at increased risk for getting very sick from COVID-19 before travel? And that would apply to most transplant patients. So I don't think that most transplant patients are ready for primetime travel at this point, which I know is discouraging. If you do travel, you'd want to think about what it would be like to get healthcare where you are going, and multiple other things that are listed here. But I would think very hard and cautiously about that. I do just want to emphasize that the CDC has clearly said that transplant patients should get the earliest, all patients, everyone are encouraged to receive the earliest vaccine available to them. I have seen some people who decided they wanted to wait for various vaccines. For example, in our situation, they wanted to wait for the J&J vaccine, which unfortunately was put on pause yesterday. So it's not even available. So they're basically going unprotected. And at this point, we don't have the data to suggest that you should pick one vaccine over another. So the best vaccine is the one that's available to you. So just in summary, any currently vaccine available is good. The side effects, as Dr. Perotti summarized, are really pretty minimal, especially compared with true disease, and especially true disease in a transplant patient. For most areas that we are in, we are not even close to ready for full opening back up from a medical perspective. And we're not ready for travel. We do see that transplant patients are less protected by vaccine. Some level of protection is better than none. And really important to cocoon the transplant patient by vaccinating everyone around them as much as possible. Future areas include, what will booster vaccines look like? Will we be recommending alternative vaccines? You know, if you had an mRNA vaccine, will we recommend one of the other vaccines for you, et cetera? And then what will that look like for transplant patients? So this is all areas under development. And now we're ready for the Q&A. And, you know, so there are a variety of questions, and we've been trying to, I'll have everyone put on their camera. And there are a variety of questions. One thing I wanted to ask is, are transplant programs making vaccination mandatory prior to undergoing transplant, like for your not after transplant, but before transplant? Because we feel that the risk to transplant patients is so high, both before and after transplant. And we feel that this vaccination is strongly recommended prior to undergoing transplant. But what do others think about that in your regions?
So at least here in the United States, it's not something that we can actually implement, because although it's getting better, not everyone has real-time access to vaccines. Additionally, we have a paper that's undergoing review currently. That's a slightly different situation. Our lung transplant patients that had COVID-19 pre-transplant had detectable antibodies and B-cell clones, that after the transplant, those B-cell clones were gone. They had no protective immunity post-transplant. And so, you know, I do think if patients can get it before transplant, I think that's great. Some of the immunosuppressive therapies may modulate the host responses post-transplant, another area where we need more information.
In the UK, Camille, the BTS, British Transplant Society, is recommending that all patients on the waiting list are vaccinated. Obviously, as you've seen, we have a very active vaccine program, good access to vaccines, and that is an issue in many other countries, I know. But in our, as I mentioned, in our waiting list has all been vaccinated, and they have to be vaccinated before they're reactivated. However, it isn't mandatory, because there will always be some conscientious objectors or medical exclusions, and so those individuals will be still allowed to be on the transplant waiting list, but others, they should be encouraged.
Camille, even in a low prevalence country like Australia and New Zealand, we're recommending that all of our waiting list patients are immunised for two reasons. Firstly, because we think it will provide an advantage after transplantation in reducing risk, but also because people with organ failure are extremely high risk of mortality should they contract COVID-19. So I think it's really important to look after our people with organ failure.
And in Brazil, I think is most part of Latin America, we can't, we recommend it, but it's not mandatory because of the limited access, of course. And here in Brazil, we are in the first phase of vaccination based on age, not on comorbidities. And we are waiting to start for the next phase when we can include all of our transplant recipients and the wait list in transplant patients.
Okay, thanks everyone. Yes, I think we should all, I guess, encourage protection for our patients and especially pre-transplant as much as possible, although it's a real challenge. There are a lot of questions about, now that we're seeing that it looks like vaccine is somewhat less protective, we don't know the full extent of clinically what that will look like. We're sort of quoting for the mRNA vaccines about 95% for regular non-transplant patients, but it's somewhat less than that for transplant patients, but we just don't know. How many of you are recommending additional doses or alternative vaccines? In the United States, we don't really have the capacity to give any more than like either one vaccine or one set of vaccines. We kind of want everybody to get vaccinated, and then we'll circle back and maybe be able to give more doses. But I know that in France and Israel, they are giving additional doses to transplant patients, which is an interesting decision, especially in France, where the minority of the population in general is vaccinated. But what are you doing in your regions?
But kind of as you've highlighted in the United States, that's not something that we have as a doable thing. Additionally, again, I think it's an area where we need to understand, is it even effective in boosting the response? I think that the first thing to say too is antibodies aren't everything. So they do protect you against primary infection, but as I highlighted in my presentation, there's also T cell production, and we know from other vaccines that T cell responses are oftentimes present even when antibodies aren't there, and those T cells prevent you from getting very sick. And so you may have some degree of benefit of protection from severe disease, even if you don't have protective antibodies.
I think in the UK, a more important aspect is the household and the transplant recipient living in a household. And currently we have an initiative to offer early vaccination to all household members of any vulnerable individual, which includes the whole transplant population, and treating the sibling, the spouse, etc., and making sure they're vaccinated is, to us, more of a priority than extra doses. And I would also say that extra doses denies somebody else a dose in the general population, which would be probably regarded as slightly unethical here in the UK at present.
And sorry, here in Brazil, we use Coronavac for about 90% of patients, and the Coronavac, as we know, is very similar to influenza vaccine inactivated virus, and we suppose that we have less response in transplant recipients in immunocompromised patients in general, and probably we are going to study and to try some alternative schedule, like influenza vaccine with third doses or double doses, but it's still early to study this. It's a very limited access to the vaccines in general.
Yeah, I think in Australia and New Zealand, we would want to see good scientific evidence that non-conventional approaches provide additional benefit before we went down that path, Camille.
Okay, thanks a lot. And I think one last question before we wrap up. There are a lot of questions in the chat about, or in the Q&A about, people who have rejection and who've been told not to get the vaccine. And I think for all of us, we would probably defer to local guidance, what your local doctor's telling you. Are there specific, we've been very pro-vaccine in general though, and so we are generally recommending it for most people, unless they just got maybe really heavy treatment for rejection, or if they are, for some reason, pretty much we're recommending it for everybody. Are there situations where you specifically have recommended people not undergo vaccination?
So the TID section vaccine guidelines do recommend for solid organ transplant patients that they defer vaccine for 1 to 3 months after transplant or recent rejection treatment, and that we recommend that be modulated based on the rate of COVID in the community. So again, I think if the rates are pretty low and we know that that immunosuppression and more immunosuppression has a greater impact on the responses, then perhaps pushing out to 3 months. Whereas if there's a lot of COVID in the community, trying to get them vaccinated as soon after the rejection event as possible.
All right, I think with that, I think we really, really appreciate everyone attending, and the speakers were wonderful, and it was great to work with all of you. This will be recorded, and so something that will be available and can be shared. And thanks to everyone for participating, and just I encourage you all to be careful out there, be safe, take good care of yourselves, and thanks for attending.